So hello, are you guys back? Are you guys with me?
Yes,
Yes,
doctor.
yes, doctor.
Good. Thank you. All right, so let's continue. We did talk about actually the most of the causes. Here, regarding the inherited disease causes, there's also, like I forgot to mention to you, there are toxins and there are drugs that are known actually to cause, the peripheral neuropathy in different mechanisms. Some of them direct, some of them through inciting, affecting, for example, a vitamin, resulting actually in the resulting in problem in putting together, if you will, the myelin sheath, such as what happened with isoniazide. So there's a long list of things, but the one that I want to mention to you here is the inherited diseases. And the reason why inherited diseases is important in this case, even though it is a pretty rare, occurrence, is the fact that actually family history is something that you need to focus on when you are asking about, the circumstances of, of the patient with peripheral neuropathy. Once you have a family history and you have a suspicion that it could be related to an inherited, form of the neuropathy, then the next step would be to do DNA studies that could be used for confirmation. All right. Okay. So what you have here, actually, you have a long list of things that we have talked about in detail, I believe, in relative detail. Careful history taking, that's going to tell you exactly, how the disease happened. Is it fast? Is it slow? Is it slow? And also, that's going to give you an idea about, family history, for example, in the patient. Physical examination, that's going to tell you, is it a large axon? Is it a small axon that got affected? And then the nerve conduction studies. Do you have actually a slowness or a nerve conduction block? Or, I mean, what you have is simply an amplitude that have become, become weaker. So that's going to tell you the difference between the distal axonopathy versus the demyelinating neuropathy. Creatine kinase is going to give you the difference between, at least when it is really high. So, a mediocre level would not really, help you much. A level that is, barely above the normal is not going to really give it to you. You need something when it becomes really really high. Creatine kinase may confirm to you that what you have is a muscle disease rather than, a neural disease or a, neuromuscular junction disease. All right. There is the CSF analysis that you may actually do to look, for example, the protein that are known to be found in very high amounts in patients with Guillain-Barré syndrome. Now, if everything fails, or if you are still not sure really what you are dealing with, then you have to resort to nerve biopsy. So even though pathology prides itself on being the gold standard, it is the venue where you have to go in order to reach a diagnosis. Unfortunately, in this case, it may tell you a lot about what's happening, in terms of, like, what you call lumping this in a bigger category. But unfortunately, it will not really, in the majority of cases, it will not give you a pinpoint diagnosis. It will not help you pin down the diagnosis, especially if the diagnosis is something else other than, for example, diabetes. Okay? Or if the diagnosis is something else other than, like an autoimmune vasculitis, because in those two patients you already have actually significant history to point you in that direction. Other than this, you're going to be left with a big category. You will be able to call it, is it axonal, atrophy, is it demyelinating, is it, Wallerian, if there is any history of that. But it's not going to pinpoint, the final diagnosis for you. All right, where is the biopsy taken from? The The biopsy is usually taken from the sural nerve which runs posteriorly to the lateral malleolus. So as a result of that, it is easy to access, easy to find and easy to access. And mainly it has sensory fibers. So as a result of the biopsy, believe it or not, that's going to relieve a small spot of hyperesthesia in the lateral aspect of the foot. Right? The biopsy is going to be sent to the pathology lab, also to the electron microscopic lab as well, to do some of the pictures that we have taken a look at today. All right, so it could actually help you, as I mentioned to you, lumping it into one of the big categories of peripheral neuropathy, but it will not actually pin it down to the final cause. The reason for this, the reason for this is the fact that actually the pathologies that are seen in in the majority of peripheral neuropathies are going to be the same really from one entity to the other. So you could not really call one you know against another diagnosis because it is the same pathology findings. All right, so we will actually mention we are going to look at some of the ones that give specific findings, such as diabetes, such as vasculitis, and finally, definitely, GBS, Guillain-Barré syndrome, that should be looked at because of its importance as a medical emergency that needs to be, promptly diagnosed and managed. All right, so starting with diabetes. So what you need to know is that again the incidence is skyrocketing. It is 42 to 55%. Imagine this: 42 to 55% of peripheral neuropathy incidence in diabetic patients. Now both type 1 and type 2 diabetes cause neuropathy. And by the time they have neuropathy, those patients will have also retinopathy and also nephropathy. All right, different patterns, for the damage that is seen in peripheral neuropathy caused by diabetes. But the most common is going to be symmetrical sensory motor neuropathy, which causes pain, sensory loss, weak or absent tendon reflexes, and to a lesser extent, weakness. Sorry, weakness. Now, pathologically speaking, it is a disease, of the axon. So it is consistent with axonal loss. That's something that you need to keep in mind. Okay. In some patients, you may see also demyelination. Now, in diabetes, you will see that the small axons, the smaller ones, are going to be affected more severely than the larger axons. Now, in the upper picture right here, what you're looking at a section of a nerve fiber of a patient with diabetes. And you can see that this is actually a toluidine blue stain again, to look for for the changes here, and you will see that all those axons have lost their myelin compared to normal. So how would you look, for the myelin and for the myelinated fibers? That is, again, the dark rings and the light, pulp, if you will. And excuse me, just 1 second, guys. I apologize. Something serious. Thank you. All right, I apologize. So again, this is a call from work, so don't think that there is anything personally. All right, so small axons are affected more than large axons, and here you will see that demyelination is part of the picture here, as you can see here. All right, so in terms of the underlying cause, you're going to see that you have probably seen that in endoripro, and you're going to see that further in endoripro of year 3. So what you're looking at actually is that there are several mechanisms, that interplay to cause the peripheral neuropathy. Primary among them is going to be the ischemia that results from the vascular changes seen, the microvascular changes that are seen with diabetes. Okay, so this is diabetes. Okay? Now, now this is the polyarthritis nodosa. So I chose an autoimmune disease, and in the upper picture here, you will see that this small artery has undergone fibrinoid necrosis. The whole arterial wall is gone. So there are a lot of inflammatory cells in and around the artery. It is in the wall of the small artery, and it has actually disintegrated that wall. Okay, so it is a necrotic wall. So you can imagine what will happen actually as a result of this form of vasculitis. There will be ischemia, and those microvessels that supply the nerves are going to actually cause a form of peripheral neuropathy. Okay, and what you're going to be finding here, so you're going to be seeing actually large swaths of the nerve that are completely amorphic material, and that's actually the tissue loss that has resulted from the ischemia, resulting in this appearance right here. There are still some few myelinated fibers, few unmyelinated fibers as well, but the majority are gone as a result of the ischemia that ensued in this condition. All right, so this is the polyarthritis nodosa. All right. Doctor? 1 second, please. Let me just, there's one slide and then we can take, as many questions as you want. All right, and finally, the star of the day is the GBS, the Guillain-Barré syndrome. Okay, so if you look here, actually, you are seeing a cuff of chronic inflammatory cells, lymphocytes, that are surrounding venules, what you call perivenular lymphocytic inflammation. Where does that happen? It happens in the spinal roots and also in the peripheral nerves. Okay, so if you, this is again that composite picture that shows you what's happening in those patients. So you will see that there are areas, or there are nerves, axons that are now recovering slightly. Okay, and that's exactly what we talked about when we talked about demyelination. That it won't have the same problem that you see with the axon injury. Why? Because the Schwann cell is intact and it's able to give rise to more myelin, to new myelin that is going to be able to actually, encase, sheath, if you will, the axons. Now, you will see from the past, as a result of the injury that happened, you are seeing those actually demyelinated axons here. And you are seeing also, how do you know that, maybe, one of you will ask, how come that you're saying this is, demyelinated? Why not? Actually, they are simply L-myelinated. The reason for this is twofold. One, if you look at the size of these axons, they are similar to the size of the myelinated axons, and you have to agree with that. This is number one. Number two, look at this one right here. In it, you still see the fragments of the myelin sheath within this axon itself. So this is actually demyelinated axons that are damaged or injured. These ones are recovering. This one has recovered fully and now have a very thick myelin sheath to it. Okay, so a couple of words about the GBS. It is the most common acute inflammatory demyelinating neuropathy, pretty rare, but its importance comes from the fact that it is a medical emergency. A prompt diagnosis should be made, and that prompt diagnosis may save the life of your patient. Start with paresthesias of the toes and fingertips, and then it will advance centrally. So from the periphery to the center, even though it is a demyelinating disorder, as we have talked. So it shows a rapidly advancing course which reaches a plateau within weeks of onset. After the weeks of onset, if the patient does not go on into respiratory failure, your patient is going to go onto his way to recovery. At the peak of the severe disease, if the patient develops a severe form of the disease, the patient may be completely paralyzed and unable to breathe. Nerve conduction study, like all demyelinating disorder, is going to show decreased conduction velocity. Now, if you do CSF study on this patient, it will show elevations of proteins, sometimes very pronounced, without significant cellularity. That's a very important point to make. So there is increased protein in the CSF, but without the cells. They call that in actually clinical chemistry, they have a name for that. They call it the albumin cytologic dissociation. You don't need to know it, but just for your information. Now, an important association actually for GPS is that it is preceded with an infection, either by a Campylobacter jejuni, by mycoplasma, or a cytomegalovirus. And that actually, that preceding infection is important because the postulated etiology is that this is providing a molecular mimicry between the pathogen and some of the components on the myelin sheath. And as a result of that, the immune system is mixing the two and attacking the myelin sheath in the crossfire, resulting in this presentation. Okay? So this is it. All right, questions now. Hello?
Yes, doctor. I have the question. First of
Can you speak up, please? Speak up if you don't mind. Thank you.
okay, the picture that you showed about the demyelination and myelination, the slide before, and also the molecular mimicry, how it's related to jejuni, Campylobacter jejuni.
Right. So molecular mimicry, this is like a big theory of autoimmunity that you have faced. There is a couple actually of theory for autoimmunity. This is one of them. So in this case, usually it is in the form of an infection. So that infection, has antigen. That pathogen has antigens that are similar to antigens that are present in the self, in the body. Okay. So the immune system will go after the pathogen, right? But because of the mimicry or the similarity between the antigens of the pathogen, of the invading pathogen, and the antigens of the self, of the body, the immune system will go after the two of them, resulting in attacking its own antigen, resulting in an autoimmune disease. Does that make sense?
Yes, thank you.
All right, so this is one. What was your second question? I'm sorry.
The demyelination, the picture before.
Which one? Can you please point me?
Yes, yes, yes. No, after that. After. دكتور
بالأخير
بعدين
after what? I'm sorry.
ايوه اخر شيء وقفنا عنده.
All right, this one here.
No. ايه اللي بعدها. ايوه this one. ايه
هذه.
Yes.
Yeah. Okay. So in this case, like I mentioned to you, demyelinating disorders, have a feature or have two characteristics. One, طبعا it is like it's a fast process. So demyelination will happen very fast, and it will present with a very like a stormy kind of a presentation. Okay, but at the same time, the recovery will be complete because the Schwann cells are intact. There is nothing wrong with the Schwann cells. So they are able to make new myelin that is going to be put around the nerves, okay? And the nerves will recover as a result of that. Not only that, it will be a complete recovery, but also it will be a quick recovery, okay? So what you're looking at here, you're looking at, neurons that were damaged initially, okay? As a result of whatever molecular mimicry, whatever you want to call it, anything that may have may have caused it. Then recovery will start to happen, and you can see actually the recovery is happening here with a thin layer of myelin sheath. Now, in the same picture, you see the fully recovered axon that is surrounded with this very thick myelin sheath. So this is the finding of all these lesions in one picture is something known as temporal heterogeneity. Temporal heterogeneity, which means finding lesions of different ages in the same section, which is what you're looking at here. Okay. Are we on the same page?
Yes, thank you so much.
All right, Helen. All right. So what else? Before I answer here, tell me, guys, what do you want to do? What do you have? What else do you have in, spoken question? Speak now or forever hold your peace. All right. So let's go back to the questions that are here. It's not recorded. Did you guys say it's not recorded?
Yes, doctor, the second part was not recorded.
How is that? Why is that? It is the same.
I guess the TA stopped the recording during the break and then it wasn't. Yeah.
Right. I think most of the talk was in the first part. It's almost like 2 hours. My God. But what I'm saying is, probably, I wish it was recorded in total, because I will send you the lecture probably in about half an hour after this. I will send it to Farah. She's here. All right. So now, what else? Let's see. What other questions do you have? How to ask the question? Ask a question. We can ask a question. This question is from Ala Al Mubayyad. Okay, ask questions here. What do you mean by symmetrical and asymmetric? Okay, symmetric meaning affecting both limbs. Affecting both limbs, both hands, for example. Similar distribution in both hands. Asymmetric معناتها it affects one hand and it misses the other. It's only affecting one limb or one hand or one foot. Okay? Let's see what else. How do we have? What do you mean? Will distal axonopathy progress to damage? Yes, of course. This is how it starts. It starts from the distal and it will spread proximally. Absolutely. Neuropathy affecting just one nerve is called mononeuropathy. Neuropathy involving nerves in roughly the same areas on both sides of the body is called symmetrical neuropathy or simply polyneuropathy. Yes, that's right. Good. Samah. Well, tomorrow's lecture is by Dr. Ahlam. I don't know how she's going to do it. I have no idea. I have two lectures, at the same time as her lecture tomorrow. Okay. All right, guys. Anything else? Like I said, that saying they say in certain circumstances: speak now or forever hold your peace. Okay. You don't have anything to say. That's good.